Thank you very much. And thank you for inviting me to this day at the University of Oulu. Well, I'm going to talk about how we can move from fragmented to integrated healthcare. And I will start to give some background on what are the causes of much of fragmentation in healthcare today, what problems this might cause, and solutions to it. So let's start very general here about some general trends affecting healthcare. One is that populations all over the world are getting older and older. For example, in Finland, 23% of the population is above 65 years of age, and in Japan, it's 29%. Another trend is that we see much progress in medical science. More and more diseases can be effectively treated, which means that many people live with serious, severe diseases for a long time. And this, of course, results in an increased pressure on the healthcare system, as we have more and more older people and also people with several diseases. And all these trends, they give rise to an increased fragmentation in healthcare. If you have many diseases, you need to meet many different specialists, and you might need also various kinds of support in your daily life with home care. And also, this increased pressure on the healthcare system has led to the introduction of more and more actors, also private actors, and the use of market mechanisms. So we get lots of different actors that are engaged in the care, both healthcare and social care of one individual. So let me back a little and say a few words here about the care process of an individual. Here's the idea that we look at the care process of one patient from one caregiver's perspective. Then you would start with some assessment where the caregiver, the physician, investigates the problems, the conditions, the diseases that the person has. Then, if needed, there will be a plan for various interventions, medications, surgery, other treatments, and then those will actually be carried out here in the do part. And finally, we evaluate how well all of this has worked out and if anything should be changed for the future. Now, this is pretty straightforward and can work very smoothly if you have only one caregiver involved and you have only this single simple process. But if you have many caregivers, we will get a number of entangled care processes involving processes at hospitals, at primary care, social care, physiotherapists, and many, many more, and the patient sitting there in the middle. And this creates a much more complicated situation. And here are some of the problems that patients can perceive and also caregivers can perceive. The patient will need to meet many different caregivers. There are many faces popping up and at his home and at the care institutions that he visits, and he has to learn about them. He might also feel that he or she has a limited control of the care situation. There are so many things happening and so many people involved in this, and the patient might not really understand what is going on. But on the other hand, it might also be that there's too much responsibility for the patient. There's no one who really takes care of this entanglement of different processes. The patient or some relative might have to take that responsibility and try to coordinate all of it. And certainly all these different caregivers being involved in the same patient increases the risks for adverse events. So clearly this is problematic for the individual patient. But it's also problematic for the caregiver. For example, we might have clashes where several caregivers visit the same patient at the same time and they can't really efficiently or effectively carry out their work if that happens. It might be that you do double work, so you have different caregivers that do roughly the same thing, which might not be needed. And again, we have these risks for adverse events. Of course, that's most serious for the patient, but the caregiver also has a problem in this, as the caregiver is responsible if adverse events take place. But when many caregivers are involved, it might not be easy to tell who is responsible for this or if it is a result of many people working together. If we look at root causes, we might see that there is overall weaknesses here in cooperation and coordination. The work processes might be inadequate, and certainly we might have limitations and weaknesses in the information and communication tools that are used here. So what can we do about this situation and what is common to do? But before going into that, I would like to make it a bit more concrete by looking at different dependencies that can take place between activities and to see how this creates issues. This is based on what I'm saying right now, is based on this classical paper on coordination theory. We might see that there are sharing dependencies, and takes place when there are different actors who require access to the same resource. For example, the same patient at the same time. We can have sequential dependencies when the order in which the activities are completed is critical. It must happen in a certain specific order. For example, that a patient must have his or her breakfast before some medicine can be taken. And this might be more complicated than it sounds if we have a patient that needs some help with the eating and also needs some help with taking the medicine, and maybe different caregivers are involved in this. And then we get this kind of sequential dependency. Even more complicated could be reciprocal dependencies when different actors are dependent on each other to complete their activities. If, for example, it could be that certain drugs interfere with each other, so you shouldn't combine them. It could be that the patient should not first have a shower and then have some wound treated. You can't do these things together or in a certain order. Now, these things might sound pretty simple and straightforward in themselves, but when there are many of these dependencies and where there are many different actors involved, all of these mount up to much bigger difficulties to handle. And we see this very much in healthcare today. So, what can be done about it? Well, one way of addressing these coordination challenges is, of course, to set up care plans, which has been done for a long time. The idea here is that you outline the healthcare activities and support activities for the daily life that are planned for a patient. It's not only the activities, it's also about treatment goals, recommended interventions, therapies such as medications, and so on. And of course, this is a good idea, but what often happens then is that this care plan is only for a single caregiver and a single individual. So a single patient could have many care plans, one for each caregiver. Another issue is that these care plans are often kind of dead documents. You set them up, and then at that point in time, you have a very good care plan, but it seems might become outdated. Another way of addressing these challenges is, of course, to have various IT tools, electronic health record systems, applications with mobile applications, patient portals, and so on and so on. And these are certainly also important ones. What we have been looking into in various projects are solutions that build on these ones about care plans and various IT tools. But what we believe is that you need to move a bit beyond the care plans that are regularly used today. We have called that active care plans. These are care plans that should be regularly updated. And in that way, it should reflect changes in the patient's status and treatment goals and care needs, and also all those planned activities. And also that you should do this on quite a detailed level. So basically, of course, it should include a core of information that helps carers to coordinate their activities. That should be both planned and historic activities and outcomes. It shouldn't be plan for each caregiver. But what's important here is to get a common plan, unites care plans of several different caregivers. It's fine that each caregiver has its own care plan for a patient, but you also need something that is, say, the union of it all. And furthermore, the care plans should not be on too abstract a level. It should be useful in the daily practice. So it should enable operational support, for example, notifying about tasks to be done, about possible clashes, about problems that appear. So in contrast to many care plans of today, it would be useful to have more concrete, more practically useful care plans that actually can support in the everyday work. And in order to make this happen, of course, you don't need only the care plan, you need also some IT tool that could help in doing that. Well, Coordination Hub is one way of talking about that. And again, the background is that we have so many tools and technologies going around today. I mentioned a few before. Today, we have learned much from the previous speakers. We have AI-supported diagnosis, self-monitoring tools, virtual augmented reality, and so on. So there are more and more IT tools, and there are many actors around the same patient, and we need to have some kind of holding all of this together. So the idea is to have a coordination tool for all the actors that are involved here, or the caregivers, but also for all the different care tools, IT tools, e-health tools and services. It should also do this, that it monitors the patient's status and activity and compliance with therapy. And it should also help the patient actually to combine and integrate new tools that appear all the time. Okay, I would then like to conclude here with a few words about ongoing projects that we have here. As you can see, what I've talked about today doesn't always require a very advanced solution. In fact, it is, as I think Minna talked about earlier, that even fairly straightforward solutions could bring very big benefits. It's not only about technical problems, it's also very much about organizational problems. And this is what we are addressing in one project here in Stockholm County and Municipality. The problem is that there are lots of different kinds of care plans that exist today. This one is in Swedish, but maybe you can still see that there are lots of different kinds of care plans. That all of these different care plans are regulated by various laws and various regulations. And there are also many different care plans for each individual disease or sector or organizational sectors. And this means that there are very many care plans going on for one single patient. And they are difficult to integrate because they are regulated and structured in very many different ways. So we would like still to move to this more active, and they want to do that in Stockholm County and Municipality, to more active and integrated care plans. But it's difficult to get started. So one idea that was the basis of this project was to start, in fact, with what's called in Sweden a SIP, a coordinated individual plan. This is not a plan that is primarily intended for the caregivers and the care personnel. It's primarily intended for the individual, for the patient. The idea is that when a patient has several diseases, they typically have several care plans. And then the idea about this coordinated individual plan is that you should compile and summarize the most important parts of those other plans and provide that to the patient, primarily for the patient's understanding and not for the benefit of the caregivers. And the idea behind this project is to try to use this idea and start with this SIP as a basis for expanding them out to and support also the caregivers. Okay, and I should also mention the second project here. Of course, health data is absolutely central and essential in all of this. This is what drives all of the coordination. And we have another project here, Health Data Sweden. When we think about this coordination, it's very much about primary use of data. It's about making data more easily available so it can support the clinical processes, the everyday processes, both for health care and social care. This project, Health Data Sweden, it is a European digital innovation hub, pretty large. Now it includes as many as 70 partners. And again, the idea here is to support not only primary use, but also secondary use of health data for researchers and also for industry, in particular for small and medium-sized enterprises. And you could see that this is, of course, there are important technical scientific problems with AI and advanced computing, but it's also very much about organizational issues that exist a lot of useful data today. And there are lots of people, both in industry and academia, that could benefit from all this data. But it's difficult for them to get access to it for legal reasons, for ethical reasons, and simply because there is no clear information about these different data sources and what they actually contain. And this is what we are trying to address in this project that started right now. And by that, I would like to thank you for your attention.
Thank you very much, Paul, for your excellent talk and all these aspects concerning this action and active care plan and also active rehabilitation plan. I really like the idea. So concerning this Swedish network of 17 centers, as you mentioned, so how is it in practice coordinated in Sweden? Is there a governmental coordinating center or are all these 17 partners like equal partners within the network without a specific coordinating center? The reason why I'm asking this is that in Norway they have this excellent e-health research center in Tromsø and this is a national center, but what is the situation in Sweden?
Okay, I would say it's more like an ecosystem with more equal partners in this project. I mean, we have universities involved, we have regions that are responsible for healthcare in different parts of the country, and they are in fact important suppliers of health data. And we also have various so-called innovation centers that are also involved here. And these are organizations whose task is to support industry in innovation and getting access to various resources in the public sector. Not the least data. Okay, these innovation centers, they don't only work on health data, data is at the center. So in that sense, the participants are fairly equal. Of course, we have a project coordinator, which is the Royal Institute of Technology, which is a university here. But I would not say that it is very centralized. It's quite more of an ecosystem in this sense.
Yes, thank you very much. And what about concerning this coordinator and coordinating center? Is the possibility for a special funding for the government or the resources for this coordinator?
You could say overall, when it comes to health data in Sweden, the situation is again a bit fragmented. I mean, we have many different authorities working on this in Sweden. Yes, the e-health authority, we have more centralized research councils. We have in fact several authorities that work on supporting e-health. And the problem here is that various initiatives are taken, but it's not clear which authority should do what. And in fact, one idea behind this project is to get more of a one-stop shop, to try to build this for the long run. Of course, this is only a project with a limited time period, but the idea is that we should hopefully be able to influence the infrastructure in Sweden, so it will become easier for researchers and for companies to get access to the health data.
Yes, we struggle with the same challenges in all countries, and thank you for these questions and for your excellent talk.